This week we're going to talk about ventilatory support in alternative settings. Providing successful ventilatory support outside the acute care hospital requires the following. Good, careful patient selection. You want to make sure that the patient that you're sending to an outside setting is the proper fit. We don't want to send a patient home with family or caregivers if they don't have the proper training and the accommodations for the home setting. Remember in the last lesson we had, if a patient goes home, there has to be certain things in the home to accommodate the equipment. For example, a grounded plug, maybe even an alternative setup in the home so that you can have all the equipment in the proper area. So it's important that you have good discharge planning when you're sending a patient to an alternative site. Key factors for success includes the following: an intradisciplinary team approach, all different areas that are taking care of the patient, whether it's physical therapy, nursing, doctor, RT, etc., need to have a care plan in place so the patient can be successful when they go to the next site, whether it's discharge planning or if they're a transfer to a different facility, they have to have orders in place to say what it is they need to do as far as the care and medications and treatment. So we have to make sure there's effective caregiver and family education, make sure competencies are done. If the patient goes home, that we can confidently know that they can take care of the patient even in emergency situations. And through assessment and preparation of the environment, making sure that the right electricity outlets are in place, they have a ramp to get into the home, and other things that may be needed to make it easier for care. And careful selection of needed equipment and supplies. So the case manager will reach out to the DME supplier, make sure they have the orders from the doctor as according to what equipment that is needed. They will take the order, send it to the DME supplier, and then from that point, the DME supplier, after clearing insurance, will make sure the supplies are delivered to the home. When we are looking at patient selection for ventilatory support in alternative settings, there are three broad categories that we will be looking at. And that's patients unable to maintain adequate ventilation over prolonged periods, patients requiring continuous mechanical ventilation for long-term survival, so they're going to live on the ventilator. And then we have patients who are terminally ill with short life expectancies. And in those cases, they may be going home with hospice and need care in that fashion, which may not always include respiratory. On table 55-5, you'll see a listing here of profiles of patient groups requiring ventilatory support in alternative settings. So there are three profile groups. You see profile 1 mainly deals with patients with neuromuscular and thoracic wall disorders. Sometimes depending on the stage of their disorder and their deficiency as far as neuromuscular and muscle weakness, they may need the ventilatory support 24 hours a day, or they may only need it at night when they're sleeping. Profile 2 requires continuous mechanical ventilation, and they need it also in conjunction with long-term survival. And there's a listing of examples of what kind of patients will fall under that category. And then last but not least, we have profile 3, which talks about the patients returning home at the request of the patient and family, and maybe they're going to be under palliative care or hospice, and their life expectancy is going to be short, and they'll go home just to be home so they don't have to die in the hospital. Or maybe that's better quality of life for them for however long they have left. And to the other side of this table, you can see the patients that will fall under that category. And for example, it has down lung cancer, end-stage COPD, and cystic fibrosis if it's bad enough. As we continue to think about ventilatory support in alternative settings, the most common setting for ventilatory support outside of the acute care hospital is home. The goal of most patients is they want to go home. They don't want to be in a hospital. They don't want to be in a SNF or facility. Other alternative sites, and I always highly recommend these because they have really good outcomes if the patient is willing to work hard and do the care plan that is necessary so they can recover. And that's the LTEC. They have excellent ways to wean the patients off of the ventilator. They do it gradually and slowly, and they also give rehabilitation during that time. And they also make it so that the patient is able to eat. And it just seems like when a patient has a swallow study, even if they're on the ventilator, if they're able to eat, it just makes a whole world of a difference as far as their recovery. It just seems overall they're just stronger than they were before, and they seem to bounce back a lot quicker than they did previously. Another option is long-term facilities with specialized long-term units designed specifically for ventilator patients. I believe the only one in this area, in the San Antonio area, is Meridian, and they fill up pretty fast, and the patients live there. And they have RTs and nursing staff on site, and the patient lives there for the rest of their life until they pass on the vent, and we don't do any type of weaning or anything. So there are facilities out there, not very many, but because, as we learned in our previous lesson, reimbursement is very small, they don't have a lot of support from the government to sustain these facilities because they just don't get a lot of money from it. There's no money in it. So these are the few options patients have if they cannot go home. So when we're looking at patients that go home with ventilatory support, it's always based on the individual evaluation of the patient's need. And one of the two following major support approaches have to be considered. So when they go home, it's either going to be with a non-invasive or an invasive way to ventilate the patient. So will we send a patient home with an endotracheal tube? Absolutely not. However, the patient can have a tracheostomy, and that's considered invasive because the airway is invasive to put it in. So we can think of an artificial airway as the way the patient will be supported in the home care setting. So invasive positive pressure ventilation by tracheostomy was the default standard for long-term mechanical ventilation, especially for patients requiring 24-hour support. However, in a long-term tracheostomy, it has a lot of potential problems. And these problems include secretion retention, infection, aspiration, and ventilatory pneumonia, as well as communication difficulties between caregivers and patients. Now, looking on the other side of things, non-invasive ventilation is usually first choice. Any individual requiring mechanical ventilation, non-invasively is the more ideal way to do it. The patient needs to be mentally competent, cooperative, and not requiring a lot of sedatives or narcotics. Anytime we are sending patients home, there's always special challenges in providing home ventilatory support. Some of the prerequisites is we got to make sure that certain things are in place prior to sending a patient home, and there's support from the family, or they have other caregivers and friends that are willing to take care of the patient in the home setting. If a person goes home for ventilatory support or even tracheostomy care and things like that, the patient cannot be left at home alone. It is a 24-hour, 7-day-a-week thing. So we have to make sure that proper support is in a home setting to take care of these needs of the patient. So you always have to have willingness of the family to accept responsibility for the care of the patient. As I had stated prior, when my father went home under hospice care, hospice was only able to come in for a couple of hours a day to help with bathing and things like that. The rest of the care fell on me and my family. So we had to kind of take turns to make sure that my dad was taken care of 24 hours a day. I took the night and evening shift, and my brother took the day shift. And it was hard to always make sure that someone was home to take care of him because he could not be left at home alone. So you always have to have willingness of the family to accept responsibility for the care in the home setting. Adequacy of family and professional support, that there's always someone that can come in and check on them outside of the acute care setting to make sure things are going well. Overall viability of the home care plan. Can they execute this in the home setting? Is this too much for being at home, or should the patient be in a facility? And a lot of times The families will fight it for different reasons why they don't want their loved one going home. Maybe they always promise mom and dad we will never send them to a home. Sometimes it's for financial reasons. If they send them to a home, then the Social Security checks end, because they will go to the facility. So there's a lot of different reasons why a family would fight to take their loved one home. But if the patient goes home, they have to be stable enough to be able to go home unless they're under hospice care. And we always have to make sure there's adequacy in the home setting to be able to maintain the equipment and the needs of the patient. On this slide in box 51-6 is a listing of criteria to determine patient stability for ventilatory support in alternative care settings. So first off, you have to be able to make sure the patient can tolerate being on a home ventilator. Being on a ventilator in the hospital setting can be a lot different from being on one in the home setting. The home setting ventilators is not as fancy, it doesn't do as many things. It's very basic, and it can feel very different to a patient than the one that they are on in the hospital. So usually when we're going to send a patient home on a home vent, we'll have the home care company bring in the ventilator like 24 to 48 hours prior to the patient going home to try them out on the ventilator to make sure they can tolerate it, that their levels don't drop because they don't have piped in oxygen in the home setting. We'll have to use a concentrator, and we have to make sure that the patient can sustain in those type of alternative settings on the ventilator. So they have to be able to tolerate the mechanical ventilation. They have to have acceptable blood gases on this ventilation. They have to have relatively low FiO2 needs. Psychologically stable. They're on a ventilator, they're not freaking out and feel like they can't breathe. Absence of life-limiting comorbidities, including cardiac dysfunction and arrhythmia, so they have to be somewhat stable to go home. They cannot go home on a ventilator that has more than 10 of PEEP. They have to be able to clear airway secretions by cough suction or cough assist device, which most of them can. Tracheostomy tube as opposed to endotracheal tube for invasive ventilation, and they have to be able to stay out of the hospital at least greater than a month without coming back. One of the things that always made me laugh is we would discharge a patient home or to another facility, and within 24 hours they were back in the ER because something went wrong. So that always tickled me. So these criteria needs to be met in order for the patients to be successful with going home or somewhere else, alternative setting. So there's always, as I have stated previously, there's always challenges to send a patient home, but with careful planning and kind of scouting the area ahead of time, it should be, for the most part, pretty successful. So the basic steps in discharge process for a ventilatory or a ventilator-dependent patient includes the following. Checking in with the family, consulting with them regarding feasibility. Is this the ideal setting for the patient to go home? You'll find a lot of kids go home with their parents, and that's pretty common. But a lot of times when it comes to adults, they don't always have the support in the home because the adult family members or wife or husband or brothers and sisters work and they have a life. So they can't always do 24-hour care. If a patient goes home, as I was saying before, they have to have appropriate physician orders written. The physician orders makes it so they can get the equipment that's needed and for insurance to pay for it. The discharge planner coordinates efforts of the team members and discharge plan to be formulated. So when the patient goes home and the family members are educated on the process of taking care of the patient, they have to have everything kind of written out for the family so there's no question as to what needs to be done. If there's tube feeds, if trach care needs to be done, when should they suction, how does that work? All those things have to kind of be in a row before the patient can go home. So physician and other team members discuss plan with family and caregivers and make sure that all their questions are answered. So they have to have adequate education and training, and they have to do competencies and checkoffs to make sure that they're competent to take the patient home so there won't be any issues. So as we continue to talk about planning, as I said before, the patient and family are prepared for discharge. Home layout is assessed with necessary changes. They usually send someone out ahead of time to scout the area of the home and look at the wiring in the household to make sure everything is appropriate to be able to handle the equipment and supplies that are given. Discharge planner meets with the team and make final preparations. And then finally, the patient is discharged. Local power companies notify regarding the presence of life support equipment and appropriate backup power. You always have to have, sometimes the patient families, depending on what it is they have, they may have to have a generator or a backup vent left in the home in case there's a problem. They have another machine to use until the caregivers from the home care company or whoever the DME is they're using is able to get there to check things out if there's a problem. And of course, there has to be ongoing and follow-up care is provided by a visiting nurse most of the time. They have RTs that come out and check periodically, and also other healthcare professionals as needed. Most of the time, a nurse aide and a nurse is the main ones that are on site checking everything outside of the RT that makes rounds and visits. So we have to think about, okay, so the patient's going home. What kind of things or lessons or education do we have to give the caregiver to make sure that the patient that goes home is successful at staying at home and not being sent right back to the hospital? So essential skills must be taught includes the following. You have to kind of educate the patient, family, or caregiver as to what looks right and what does not look right. When is the patient in distress? When do you need to call for help? When is things not going the way they should? So a simple patient assessment. We don't expect them to know things as we do because we went to school, but they need to be able to recognize if the person is in trouble with their breathing. So they have to be able to learn the basics of airway management, including trach and stomach care, cuff care, suctioning, cough assist, and changing artificial airways and ties. So we make sure they're proficient and they can demonstrate to us before they leave how to do these things. Chest physical therapy techniques. Sometimes the patients will end up with a therapy vest or some type of percussor type device, or maybe even hand percussion. We would teach all that to the family members so they can make sure that these therapies continue in the home care setting. What kind of medications the patient should be getting, nursing or nebulizer treatments. Make sure that they know how to get the medications from the pharmacy. Patient movement and ambulations. A lot of times the equipment company will give them Hoyer lifts and things like that to help the patient into the chair. Let them know what the patient can and cannot do without help. We educate them on equipment operation and the maintenance, how to troubleshoot the equipment to a certain degree. If they cannot figure out what is wrong, they definitely need to call the RT or the nurse or whoever their contact company is. And that's why sometimes, depending on how far away they are from the home care company, they may have extra equipment in the home to switch out to until the caregiver or RT can make it to the home to check everything out. We teach them also how to do proper cleaning and disinfection, and then we also teach them emergency procedures if the ventilator or was to not function properly or have a power failure, or if they have problems with the circuitry, airway emergencies, and also cardiac arrest. So when we're teaching the patient's family member or caregivers or whoever the designated person is to take care of the patient, it takes a process for these patients to learn the different skills. We don't just kind of train them one day and then send them home. Most of the time, the planning for the patient to go home, once it's determined that they are going home, is usually done over several weeks. So we set out a specific time frame depending on the caregiver and their availability to come up to the facility for training. Training usually requires 1 to 2 weeks. We'll make sure if we're in the acute care setting that we'll hold off on doing certain skill therapy and things of that nature to give the family member or friend or whoever is the designated person is time to get up to the hospital to learn these skills and do the return demonstration. So we have educational sessions where we give them a booklet, show them what they need to do, have them do a return demonstration for us, give them time to practice, and then we evaluate and document all of these things. And it's very highly recommended, if possible, for the caregivers to complete basic CPR prior to the patient going home. Here's another list, 55-3 of long-term invasive mechanical ventilation in the home guidelines. According to the AARC clinical practice, some of these I've already have mentioned, but just so you can familiarize yourself, be sure to read this list of the indications and contraindications for being in the home. So we're doing a compare and contrast of invasive versus non-invasive ventilatory support. When we think of invasive positive pressure ventilation, pretty much all the time, and I rarely ever see anything outside of this, the patient, if they go home, they're going to have a trach. It's easy to manage. You can do trach care. You can change up the inner cannula depending on the style of trach that they have. So I would say 99.9% of the patients that go home have a tracheostomy if they require 24-hour support. Many complications occur with long-term trachs, as I have stated before: secretion, retention, infection, aspiration, and VAP, which is ventilatory acquired pneumonia. Many LTECs treat trachs as an open wound. Certain sites are prohibited for discharge. So if you have a patient, a lot of times they do get sores and things like that, but then the LTECs, they can treat it with proper creams and medications, so they can go home and not have the high risk for infection. Invasive ventilation by trach poses significant limits on the patient's quality of life. So they can't be as mobile as they would like. Some of them are if they're ambulatory, but it makes it easier for care in the home care setting if they have a tracheostomy. On the other side of things, when we think of non-invasive ventilation, which is abbreviated NIV, involves any method designed to augment alveolar ventilation without the support of the endotracheal airway. So individuals that meet the following criteria can be supported with non-invasive ventilation. As I've said before, the patient needs to be mentally competent, cooperative, and not using any type of heavy sedation or narcotics. They must be on lower level of oxygen as far as FiO2, usually less than 40%, and their SaO2 or SpO2 saturation must be able to be maintained at greater than 90% in the home care setting. Bulbar muscle function is adequate for swallowing without potential for aspiration. No history of substance abuse or uncontrollable seizures, and no conditions are present that interfere with non-invasive interfaces. For example, facial trauma, facial hairs, etc. So who are the patients that could benefit from having non-invasive ventilation in the home? The patients who can benefit from non-invasive ventilation generally fall into two categories, and that's patients whose condition in which cessation of ventilation could lead to imminent death. Acutely ill patients with long-term 24-hour support patients. So an example of that will be patients who have on and off problems with exacerbation of COPD, maybe pulmonary edema, or patients with neuromuscular disorders or quadriplegia. And then you have the other patients that may need ventilatory support non-invasively, and that's patients who need it for clinical benefit, but sensation is not life-threatening or intermittent, or for nocturnal support. For example, patients who have obstructive sleep apnea may also benefit from using the non-invasive ventilation CPAP. Some contraindications to non-invasive ventilation is severe upper airway dysfunction, copious secretions that cannot be cleared by spontaneous or cystic cough, and O2 concentration requirements exceeding 40%. In box 51-8 is a listing of absolute contraindications against using non-invasive ventilation, and that's the patients that are in need of immediate intubation, hemodynamic instability, uncooperative patients that won't follow instructions or plan care, facial burns or trauma, inadequate airway protection, and patients with tracheoesophageal fistula. And this concludes our lesson for Unit 2, Section E, Part 1.